All right, so I'm going to talk about adhesive capsulitis. It is the great imitator, and some of the things that Dr. Meyer just talked about can seem more obvious when you get a little bit better physical exam and a history, but there are times when that's not very easy to distinguish. So we're going to go through adhesive capsulitis and discuss when that is a more obvious diagnosis. So the definition of adhesive capsulitis is a gradual loss of both active and passive range of motion, specifically the glenohumeral joint. Codman originally described this as tendinitis, which involved bursa and spasm, which we understand really probably is not the pathology, but Navazier and Joe Hannafin have really described this more as a continuum of a pathologic lesion that starts with inflammation of the glenohumeral capsule, followed by fibrosis, and then capsular contracture and thawing or loosening up. So most patients who present with this come in with a fairly similar story, but it only occurs in about 2 to 5% of the population. Women far more likely to get this than men, typically in that age range between 40 and 60. Interestingly, a lot of patients who get this and recover from it will develop it in the other side. There may be some obvious reasons for that, there may not be. And very often it happens in the non-dominant arm. So whereas you may see things like a rotator cuff tear injury, tendinitis, or more acute injuries in the dominant arm, this can often be in the non-dominant arm. So risk factors for adhesive capsulitis, I think we're all very familiar with the risk factor associated with diabetes, but it can also be associated with thyroid dysfunction, certain types of cancer such as breast cancer, possibly autoimmune diseases, cardiovascular diseases, and a certain percentage of patients will actually describe there was some inciting event or trauma or incident that started this process. And so you can be confused a little bit by that as well. But primary adhesive capsulitis, which is a little bit different, is idiopathic. We don't really understand what starts it, but it starts with inflammation of the capsule, followed by fibrosis, and there's really not another explanation or reason for why this is occurring. That'll be a more primary type of capsulitis. But secondary adhesive capsulitis, which probably as surgeons we may be a little bit more familiar with, is typically as a result of something else. Sometimes it's calcific tendinitis, sometimes it's rotator cuff disease, sometimes biceps tendinitis, arthritis, which is very common because you do lose glenohumeral motion with both arthritis and adhesive capsulitis, and then sometimes after surgery. So in these incidents where it can look like or mimic these other things, we need to treat the underlying pathology if it's there, and if not, then consider it being a primary form of adhesive capsulitis. So the stages of adhesive capsulitis, as I said, it's really a continuum. Sometimes it's really hard to go through the literature on this because there's so much variability in when it's being reported and what type of treatment is being given at what stage. So it's a little bit controversial what the ultimate course of this is going to be, but it does tend to follow a pretty consistent continuum, and we'll go through that. So stage 1 is really kind of a gradual onset of pain. People will just tell you it started to hurt or ache. It's often referred to the deltoid insertion. It's usually achy at wrist, but can be worse with movement. Oftentimes pain at night. It's hard to sleep on that side. Usually it's limited in duration. Typically when you're in this stage, it's less than 3 months, although that varies quite a bit. Pain is difficult to palpate, and they have pain with passive motion. And everything I just listed there could be associated with almost any shoulder pathology. So this is one of the reasons it can be difficult to identify this as the pathology and why it's considered a great imitator. But in stage 1, what's happening is they're starting to lose a little bit of, as Dr. Meyer pointed out, external rotation specifically. The rotator cuff is usually intact, meaning that their strength is intact. And if you, at this stage, inject just lidocaine or any type of intra-articular anesthetic, you can restore that motion pretty easily. It's pain that's causing the limitation. You can do diagnostic testing at this stage, and often do, because you're not certain if it may be something else or one of those other pathologies. So very often you'll be doing MRIs and things in this stage, and it can be hard to interpret that. But what you'll see if you scope someone in this stage is a lot of inflammation, all that hyperemia, erythema, especially throughout the capsule. You may see a little bit of contracture or loss of some of the capsular space, but typically not. We don't often scope people at this stage, so it's a little bit unusual to see it, but you may incidentally scope someone because there's some other concomitant pathology and see this. And histologically, if you take a biopsy, what you'll see is a lot of inflammatory markers, inflammatory cells, hypervascularity, a lot of synovitis. But the capsule itself will typically appear fairly normal, and that's because it's early in the stage. Stage 2, which is the freezing stage, in that stage the pain is persistent. It could be getting worse, it may not be. Usually the motion is decreasing, so typical for when something is freezing, it's starting to get tighter. Most often you'll see this, I would say, in internal and external rotation, most typically external, but then forward flexion, abduction, but that can be later, and that mimics a lot of other diseases. And at this stage, sometimes you can get some of the range of motion back, but typically not completely. If you try an injection, they'll still have sort of a hard stop or a tethered feeling when you try to range them. So what stage 2 looks like is arthroscopically, you start to see thickening. Some of that, it's starting to turn a little bit more white. You might see synovitis, such as this on the top right, this Christmas tree appearance, which is these large fronds of synovium. The axillary patch will start to be obliterated. So when you're trying to get down there inferiorly, there's less room just to get your scope down there. And histologically, you'll see more of this hypertrophy at this point. That hypervascular synovitis that you see in the top right, you can see in the very bottom slide histologically. And you'll start to see blood vessels forming around that synovium. And it could start to now look, the capsule can start to look more fibrotic in this stage. Stage 3 is really the frozen stage. And most people will come in complaining not that much of pain, but now it's just very, very stiff. Pain may be more obvious when you're really at the end range. So when you really force them into external rotation, internal rotation, abduction, it hurts just at the end of that. And usually it'll be more of a solid block. So it'll feel like it just stops. Things like loose bodies and mechanical things in the shoulder are not that common. So if I see sort of a solid block with motion and it fits some of the other descriptions, I'm considering it more likely to be adhesive capsulitis. And if you inject them just with lidocaine at this point, you typically don't see much improvement in motion. Usually this is later stage in the 9 to 18 month time frame. And oftentimes we won't see a patient until this point. Arthroscopically, really difficult to see. Sometimes you put a scope in there, and if you haven't done any kind of manipulation at this point, it's hard to really tell where you are. You just see a lot of white, dense tissue. Histologically, it's very, very dense. It's hypercellular. It looks very, very fibrotic, and the synovium is much thinner. So instead of seeing those inflammatory and vascular areas, you're just seeing sort of a sheet of dense fibrotic cells, which you can see on the bottom of the histologic side. On the right in the cartoon, this is just showing how that axillary pouch sort of disappears and how the capsule tightens up. In stage 4, the thawing stage, really typically won't have that much pain. They may gradually start to improve their motion. Depending on how often you see them, this may seem gradual to you. This may seem like it takes forever, but it is oftentimes very, very slow. And this can be difficult to manage just because the expectations from both the providers and the patients are much higher than how long this can take. In the stage 4 thawing stage, oftentimes arthroscopically, you really don't see that narrowing of the capsule, but you see that dense white, just scarred looking capsule. You might see some obliteration of the joint space depending on when you get in there, you may not. But histologically, because this is a hard stage to identify, there's not really a good accurate description of what this looks like. So I don't have information on that, but I think you can probably assume that you're going to see those mature fibrotic bands with less vascularity and really less active inflammation going on. So the natural history historically has been described as self-limiting, but that's pretty difficult to interpret. Most studies that you look at will describe some type of treatment, so that it's rare that we just leave people alone and do nothing. So it's difficult to know if that's actually effective treatment, but historically has been described to be. There's a lot of studies on this, and a lot of the levels of evidence are fairly anecdotal. In general, most of the studies do point to the fact that if you do little, meaning reassure, anti-inflammatories, they will get better without any intervention. Particularly early on, a lot of people will do physical therapy and sometimes, and passive motion. Sometimes that can aggravate symptoms, and sometimes it's very helpful. So when you look through this, it's hard to know when the right time to do therapy is. So I do typically include therapy as part of this protocol, but I think the timing of it and this type of therapy is very important, especially for the right outcome or improvement that patients can start to buy into. So most of the time, these studies rely on patient-based outcomes that tend to be more favorable. but physician-based outcomes or objective-based outcomes tend to be less favorable. And I think part of that probably has to do with, as physicians, as surgeons, we want our patients to get better, and it's very, very difficult to just sit and wait in this situation. But the treatment still is somewhat controversial. Generally, if patients have prolonged pain, disability, and limitation of function, we do something. And I will say that that has changed over the course of my career dramatically, where we were more reassuring early on. I think more and more patients demand some type of intervention at some point, typically earlier on. So really optimizing the treatment depends on knowing what stage of disease you're in and providing the intervention that's appropriate to that stage. Non-operative treatment, anti-inflammatories can be helpful when they're in the inflammatory stage, so in stage 1 or 2, but it doesn't really change the natural course. It just makes their symptoms a bit better through that portion. Oral steroids can give more rapid relief, but they don't necessarily alter the course either. None of the studies have really distinguished the stage of the disease at the time of treatment. So again, this is difficult to interpret, but we'll apply some principles to this. Intra-articular steroid injections, I found this to be very, very helpful, particularly if they're in the early inflammatory stages, stage 1 or 2. A lot of variability in the evidence for this, but if you think about the pathology and the fact that this is inflammation, decreasing inflammation can really just help your patients feel more comfortable. May also help them tolerate physical therapy better. Steroid injections in earlier stages seem to be more effective because you're treating inflammation rather than the fibrosis and the scarring. So physical therapy, almost any intervention supports using physical therapy, and almost all of them get some. Physical therapy alone doesn't necessarily do better than physical therapy with other interventions and may actually do worse, particularly if you push them to the level of pain. They may get a rebound, more inflammation and more pain, and then they don't move as much because it hurts. May not be actually worsening the process, but maybe limiting the patient in terms of their anticipation of getting better. So gentle stretching, active motion, staying in pain-free zones seem to be more efficient or more sufficient than doing anything painful. Operative intervention is a bit, I would say, controversial. Most of the time, if things have been going on for a long period of time, and I won't define that, most of the time that's defined by both the surgeon and the patient, they may end up getting some type of operative intervention. And about 10% of patients won't respond to anything other than operative intervention, so not a high percentage. And indications for invasive treatments such as surgery are more subjective, individualized, and I would say controversial. Suprascapular nerve blocks. This has gotten some attention because what you're doing is interfering with their perception of pain, which can allow them to participate in things like physical therapy a little bit better, or to be patient if you think that the natural course is that it will get better on its own. And it does work for pain, but it doesn't necessarily work for improvements in function or to alter the speed or the process of the disease. Hydrodilation, I think, this is something that Dr. Hill is going to speak in a little bit, has done quite often in our patients in our clinic. And I found this to be very, very effective, particularly in that stage 2 or maybe late stage 1. If you do this with a steroid, with lidocaine, and with a high volume of saline, you can actually distend that capsule and increase the range of motion pretty quickly, similar to what you would do in a manipulation or potentially arthroscopically. So it increases the capsular pressure. It may rupture the capsule, which is what you're essentially intending to do. If you have experienced practitioners, which we do with Dr. Hill and Dr. Spittler, who've been doing this for us for a long time, it really is effective, and I've been really happy with this. Not a lot of data on this, and I think because it varies so much in terms of how the practitioner technique is, that you really want to get someone who's familiar with this and does it well. Manipulation. Consistently, there's good results with manipulation, but I think considering the potential complications, particularly if you have an older patient who may have lower bone density, fractures can happen. You can rupture the subscap, the labrum, the biceps. None of those are necessarily common, and I would say fractures what we worry about the most. And so if you're doing a manipulation, you want to be doing more of a gentle manipulation, maybe a bit more than what the therapist can do in an awake patient. But this is something that does work, particularly if you don't have to do anything that requires a significant amount of force. And in that case, you're going to consider intervention. But it is a good modality, excuse me, and they typically do get range of motion better earlier with manipulation. I'll skip through some of those studies and go straight to arthroscopy. I don't do this very often. I don't know how many of my partners that do more shoulder surgery really do this, but it can be done with or without a manipulation. I think most people who do this will scope first, do a capsular release, and then manipulate to sort of get those end ranges. It's a little bit controversial which one you should do first, and I would say in my hands, if I can't get the scope in or they're very, very tight, doing a small gentle manipulation first may help you get the scope in, but then I think it's a bit safer to do your capsular release and then do one more, I don't want to say aggressive, but more significant manipulation after that. You can do a synovectomy, remove some of that inflamed synovium. You don't want to cause a lot of scarring because you may get a bit of a rebound, but arthroscopy can be very beneficial in more refractory cases. Basically, I just summarized what some of these studies say, and you'll have these slides. You can look these up if you'd like. How much capsule to release is a little bit dependent on the treating surgeon. I think you want to release enough capsule to allow a normal range of motion within a functional range. It doesn't have to be exactly symmetric to the other side. You can get a little bit more stretch with manipulating it after you do the release. So this is very individualized and surgeon by surgeon. Open releases are almost, I want to say, never performed unless there's some other pathology going on. So if you have some type of trauma that's ended up in adhesive capsulitis as a secondary cause, you may need to go in and do an open type of release, but this is very uncommon, and I would not do this in a diabetic because the chances of them having even more stiffness are much, much higher after an open release. So algorithmic treatment, I kind of went through this already, but basically in stage 1 to 2 disease, I'll do a steroid injection or a hydrodilation injection if they're really getting tight. Oral anti-inflammatories can be helpful if they're not contraindicated. Physical therapy within pain tolerance and home exercises. In stage 3, we'll do physical therapy to continue to mobilize them a bit using heat, passive stretch, active warm-up. I would say I do a lot of reassurance in stage 3. You can push the motion a little bit because they're not as painful, and hydrodilation may be helpful here. At stage 4, it's the same as stage 3, but then you're going to start considering intervention, whether it's a arthroscopy, manipulation, or combination of the two. It needs to be very individualized. If you have a patient who can be patient, sometimes you can wait a little bit longer. But if you do any of these interventions, you want to follow that up with therapy right away. So in conclusion, the treatment of this is still a bit controversial, but there is a linear algorithmic approach to this. Most of the literature is not very helpful to inform what type of treatment, but you can use principles of treatment to help guide you. Clinical stages are very, very important in this. I like intra-articular steroids and hydrodilation in early stages. Manipulation can be effective, arthroscopy can be effective, but we need a little bit more higher level studies, less opinion and less anecdotal evidence to really understand the appropriate treatment. Thank you.